Gonna get ready with oral abstract presentations. This is a huge highlight for the meeting. Everybody hopefully take your seats, come in from lunch. We've got a super exciting session for you all. All right, everybody gather to your seats. Just like everybody's. Simon says, find your chair. Simon says, sit in your chair. Okay, very good, very good. All right, everybody. My name is Raina McKay. Excited to be moderating this session with my colleague and friend, Yüksel Yern. We're going to just go ahead and get started and kick things off. We'll have our first speaker come up, Dr. Laurence Albiges, presenting new data. Belzutifan versus Everolimus, subgroup analysis from LIGHTSPARK-005.
Thank you, Raina. Well, it's my great pleasure to present on behalf of my co-authors the subgroup analysis within the phase 3 of LIGHTSPARK-005, which tests Belzutifan versus Everolimus in previously treated patients. So I think this audience is familiar with the study design to the right, which basically enrolled patients with clear cell RCC, previously treated with at least one PD-1 and one VEGF-TKI, up to 3 systemic regimens prior to study, which randomized patients to receive either Belzutifan every day versus Everolimus. And so the primary endpoint was progression-free survival, assessed by Becker. So the study has been presented last ESMO, and the study clearly demonstrated hitting or meeting the primary endpoint of progression-free survival benefit with a hazard ratio of 0.75. Also a benefit in terms of response rate, about 20% versus 3.5, and also a great safety profile. So based on this finding, the drug has been approved by FDA since last December. And so today, what we will be presenting is the efficacy and the safety results from LIGHTSPARK-005 within 3 different pre-specified subgroup analyses: the IMDC risk group, the number of prior line of therapy, and the number of prior VEGF-TKI. So I'm going to walk you through the baseline characteristic of those different subgroups quite promptly. To start with the IMDC risk group, I have stressed that those patients were previously pretreated. So we anticipate to have few patients that are still IMDC good risk, with all the limitation around the IMDC in those very, very late lines. It's about 80 patients per arm that were still good risk. The vast majority, about 300, being intermediate and poor in each arm. The second subgroup we'll be looking at will be the number of prior lines of therapy. 1 prior line versus 2 prior lines versus 3 prior lines. I'm going to draw your attention to the 1 prior line. It's only 50 patients per arm, but it means that basically those patients had VEGF-TKI plus IO combination regimen as frontline, and then were randomized to the study as a second line. But the vast majority of the patients were either treated with 2 prior line or 3 prior lines, about 150 per arm with 2 prior lines, and about 170 per arm with 3 prior lines. Now, the third subgroup we'll be looking at is the number of prior VEGF-TKIs. So not the number of lines, but really TKIs used. And so here again, we have a split between patients that only receive 1 prior TKI, about 180 per arm, versus 2 or 3 prior VEGF-TKIs. So let's dig into the results now. Progression-free survival assessed by Becker is the study primary endpoint. What we are seeing on this slide is that irrespective of good risk or intermediate and poor, we have a very consistent hazard ratio of 0.74. Of course, the number of patients that were IMDC good risk are limited, as I'm stressed, but I'll draw your attention to the median progression-free survival of about 11 months for those patients who were receiving Belzutifan versus Everolimus, about 7 months. Intermediate and poor, the vast majority of the patients are in the line of what we previously presented in the overall patient population, around 5 months median PFS. Moving on within the same subgroup analysis to overall survival, these data are presented with about 2 years median follow-up, that's 24 months. What we are seeing is a median overall survival in good risk of 30.4 months for Belzutifan arm versus 25, and a hazard ratio below 1 at 0.75 This is clearly a small subset of patients. And in the intermediate and poor, the most common situation was associated with also a hazard ratio below 1. But for now, we still have to have more follow-up. I'm going to move on to PFS by number of prior line of therapy. I'm going to draw your attention to the left part of the slide. Patient who only had one prior line, meaning VEGF, TKI plus IO as their first line, and then Belzutifan or Everolimus as second line. Median PFS here is 9.1 versus 5.6 and a hazard ratio of 0.54. Once again, limited by the number of patients in this situation, but quite informing to our practice, I believe. 2 prior lines or 3 prior lines had respective hazard ratio of 0.81 and 0.77. This is overall survival by number of prior line of therapy. I really believe that we need more follow-up to better have a view on the situation of overall survival in this trial. And so now moving on to number of prior line of VEGF TKIs, 1 prior line to your left, 2 or 3 prior line to your right, very consistent hazard ratio for PFS of 0.77 and 0.73. This is the overall survival by number of prior VEGF TKIs. All of them of their hazard ratio are below 1. What about response rate? What this slide is showing us is that irrespective of the subgroup you're looking at, IM series group, number of prior line, number of prior TKIs, we have a very consistent hazard ratio in the range of 22, 25, up to 28%. So that shows us that Belzutifan was able to achieve significant tumor shrinkage in about 1 patient out of 4. And this, of course, compares well compared to Everolimus activity there. With regard to adverse event, there is no new signal that is coming out of this subgroup analysis. You may remember that Belzutifan is associated with a very interesting safety profile that makes it the right candidate to go for combination therapy. And this is the incidence of all-cause AEs that are leading to treatment discontinuation. The green being Belzutifan, very little numbers of patients that required treatment discontinuation. So I'm going to wrap up on saying that LIGHTSPARK-005, progression-free survival, response rate, favored Belzutifan versus Everolimus across the different subgroups that I've shown you, IMDC risk group, number of prior line, and number of prior VEGF TKI specifically. In the primary analysis, OS did not reach the statistical significance, and we will wait to see more in the future. We had fewer AEs leading to treatment discontinuation within the Belzutifan arm versus Everolimus. And so overall, the safety in those pre-specified subgroups were consistent. And these results support the use of Belzutifan as a new treatment option for patients with advanced RCC who received 1 prior TKI at least and 1 PD-1 inhibitor. And I would like to thank you for your attention and thank Merck for the opportunity to present this data.
We're going to do questions after the first 3 speakers. So Dr. Choueiri.
Great. Well, thank you for the second day. And this is new data that you're going to see the first time presented here at KCRS24. This is the safety profile of Belzutifan monotherapy in patients with renal cell cancer overall. That's a pooled analysis of 4 clinical trials, just focusing on safety and specific side effects. My disclosures. So in terms of background, don't need to tell this audience anymore, at least now, that Belzutifan is approved, the HIF2 inhibitor at 120 milligram once a daily in the US. The 2 indication, of course, VHL disease-associated renal cell cancer and associated with CNS hemangioblastoma, PNET, not requiring immediate surgery, or adult patient who have clear cell RCC previously treated by a VEGF TKI and at some point a PD-1 or PD-L1 inhibitor in sequence or combination. This class of drugs, and Belzutifan specifically, has a unique mechanism of action, a distinct AI profile. The 2 most important are anemia and hypoxia. So what we did, we looked at these 4 studies, LIGHTSPARK-001. That was the first, data about Belzutifan, 58 patients. We looked at LIGHTSPARK-004. That's the VHL disease study, 61 patients. The arm of Belzutifan from LightSpark 005, 381 patients, that's the bulk, as well as LightSpark 13, that's the randomized phase 2 study, 76 patients that was led by Dr. Niraj Agarwal. The pooled population was over 500 patients, 576 patients. No surprise in terms of the age as well as the sex, specific for renal cell cancer. Most of the patient has ECOG performance status 0 to 1, and the majority were enrolled either in Western Europe or North America. So let's start by looking at this aggregated data. So if we look at any cause AEs, important to look at the serious one, 41%. Again, this is any cause, related or not related. And in our reporting system, that I think is completely inadequate, but we live with it now, is, you don't have anymore for many years now, whether it's partially related, probably related, possibly related, it's yes or no. So overall, 50% of patients needed some dose modification, 40% some dose interruption. Dose reduction, though, only 15% of patients. Treatment discontinuation, completely giving up on the drug, so that really probably because of grade 3, 4, or 5 toxicity is 6.4%. And when look at the one that for sure are treatment related, these numbers always go down. So one treatment-related deaths less than 0.3%. Now, this is the any cause AE for incidence, any cause AEs with incidence more than 10%. Grade 3 or 4 anemia, close to 29%. Hypoxia, again, this is on target, 12%. Anemia and hypoxia always come at 1 and 2. This is also new, the time to the first onset of common any grade, again, any grade AE related, any grade AE. So from grade 1 to 5 attributed to Belzutifan. Again, the anemia and hypoxia are the most common. And you have to think here around 1 month, 29 and 31 days, the median. But if you look at the range, and that's minimum and the max, this is how the data is captured. It can be quite, late. Some people after, a year, fatigue, nausea, dizziness, been reported. Dyspnea too, as well as weight increase. And we can go back to why is that. So the summary of any cause anemia, 84%, 29% almost grade 3 or higher, almost a month. That's the median time to onset, and median time to onset of grade 3 or more anemia around the same time. But the resolution is around 70 days. So how do we manage these patients? Now, if you look at the protocol, and we still, do not have a clear path what to do, but we have, suggestions, because we leave that mostly at the discretion of the physician. And how did that end up? And mostly it's between ESAs and or blood transfusion. 23% of patients received ESA, 17.5% blood transfusion, and there are those patients that receive both ESA and blood transfusion. There are some patients that receive other treatment in addition, sometimes, of ESA and or blood transfusion. Any folks still, a lot of oncologists, they see patients, they give them B12, vitamin, iron, and that's under other treatment. The median time to using ESA is 85 days, and median number of injection per patient around 5. So this is not how you treat patient on dialysis, patient on HIV. Usually few doses, are okay. Overall. In terms of blood transfusion, 2 blood transfusion average when blood transfusion are used. What about hypoxia? 12% is the number to remember for Belzutifan for patient with grade 3 or higher hypoxia, and still around the same time as anemia in terms of median time to onset. Have this 1 month, 29 to 30 days, 31 days in your head. The median time to resolution is 11 days. There are some patients that needed oxygen, around 70%, and any oxygen, even for a day is is captured, but the duration of supplemental oxygen has been, on average, the median is 9 days. So overall, in terms of conclusion, Belzutifan has a generally manageable side effect profile. Few patients discontinued treatment due to Belzutifan adverse event. That's a pooled analysis from 4 clinical trial of 576 patients. Adverse drug reaction, anemia and hypoxia especially, has a relatively early onset, in months. And the median time usually occurred, most of them within the first 3 months, 6% only treatment discontinuation. Again, keep in mind anemia and hypoxia, and these were managed with dose modification, ESA, blood transfusion, supplemental oxygen. This is currently the largest pooled safety data set for HIF2 inhibitor. We need to be familiar with this is a new drug with a new mechanism of action. Again, these are the sites and the PIs that need to be thanked. Hundreds of sites. Some folks opened, more than 2 studies. I want to specifically thank all their participants, patients, and their families, and the Merck team here with their leadership, Kathy, Rodolfo, and Joe. Thank you.
Great. Our next speaker is Brad McGregor from the Dana-Farber.
Thanks so much and the opportunity to present our work. So I'm going to be presenting data from a phase 1b trial of Abemaciclib in advanced clear cell renal cell carcinoma. So why even do this trial? Why do we think about CDK4/6 inhibition in renal cell carcinoma? I think everyone in this room knows the role of CDK4/6 inhibition. We look at progression from G1 to S phase, important checkpoint, mediated through RB. RB is expressed in 95% of RCCs, and there's a lot of work that's been done that has showed that there could be a rationale for CDK4/6 inhibition in renal cell carcinoma. A lot of this has been preclinical. There's some really interesting data where one of the CDK4/6 inhibitors had marked inhibition of RCC proliferation in nanomolar doses. And then there was some great work from the KCRS lab where they showed that palbociclib seemed to have a synthetic lethality with HIF2 inhibition. But regardless of HIF2, there seemed to be some monotherapy activity as well. Abemaciclib in combination with sunitinib has caused dramatic reduction in tumor sizes without overt toxicity in preclinical mouse models. So there's a lot of this preclinical data, and there's actually a lot of trials that are ongoing that are looking at CDK4/6 inhibitors in renal cell, often in combination with other agents. But as we look through the literature, despite all these trials that are ongoing, there's actually no dedicated trials to date that tested CDK4/6 inhibitors in monotherapy. We actually went back and looked at the phase 1 trials when they first developed these drugs, and we really couldn't find any data for the activity of CDK4/6 inhibitors. So we were really excited about the KCRS paper showing this potential for synthetic lethality. So we actually were looking to design a trial where we want to test the combination of abemaciclib with Belzutifan. And also, as we designed, we said, well, we really probably need to know what is the role of CDK4/6 monotherapy. So we had this great trial. Whole protocol was written, submitted to the FDA, and then Merck bought Peloton and bye-bye Arm 2. And unfortunately, I don't think it's going to be coming back anytime soon, despite a lot of pleas. So we are left right now with the Arm 1 of single agent abemaciclib. So this is the primary objective: enroll 11 patients, really looking to evaluate the objective response rate of abemaciclib. Planned sample size was 11 patients to allow a 0.8 probability to observe 2 or more responses, basically if the ORR was 25% or higher. So a relatively low bar. So who was enrolled in this trial? So median age was 62. I think what I really want to point out is the number of prior lines of therapy, and that it was 4, but ranged anywhere from 1 to 9. So these were heavily pretreated patients. And to the comment we made earlier about when should we be looking to use phase 1 trials, and think about this, this was not used early on. A majority of these patients had multiple lines. Median number of prior cycles was 4. We can see that there was 2 patients with sarcoma differentiation. We actually had 1 patient that had some translocation features, which we're really excited about based on some work from Choueiri. So what did we see? Unfortunately, that's a very depressing waterfall plot. So no patients had an objective response. A majority of patients had like marked growth in their tumors on first scan, which was done at 8 weeks. 1 patient had stable disease with growth, which was like the least impressive growth. That was actually our patient with translocation renal cell carcinoma. That translated into a pretty depressing PFS of 1.8, a mean overall survival of 9 months. So we really didn't see any meaningful clinical activity with single agent abemaciclib in heavily treated clear cell renal cell carcinoma, or that 1 patient with translocation as well. So what about toxicity? So I think if you look at the toxicities, if you look at the table, it looks like it's not that bad. It looks like this is very manageable, minimal issues, some elevation in creatinine, some patients with diarrhea. I will tell you though that overall patients just didn't feel great on the trial. So while there's no grade 4 or 5 adverse events and only 7% of patients had grade 3 adverse events, I think that this was a therapy that the patients definitely appreciated they were on. And it wasn't really the nice break from TKI therapy that we were hoping for. So all in all, like, what does this leave us? Like, why am I even up here talking about a trial with such negative results? And I think it's really important because there are ongoing combination trials, right? So LIGHTSPARK-024 is looking to combine Belzutifan with palbociclib versus Belzutifan alone. And we need to have an idea of contribution to components, right? We saw this with the Nivo-IPI data in the front line. It's like, well, do you really need the IPI? Is it one or the other? And so now at least we have this limited data set, 11 patients that showed abemaciclib did not have any single agent activity. And if we see a marked improvement in outcomes with a combination of Bel plus Palbo, it would really imply that like that synthetic lethality that we saw in the preclinical models is there. And then we actually have Spark. So it used to be a part has gone away as we're not using avelumab. So Spark, we're going to look to combine sasanlimab with axitinib and palbociclib in frontline treatment of renal cell carcinoma. And so again, this will just give us some idea of how we can really interpret this data going forward, as well as others. There was a trial in progress looking at sasanlimab with palbo in divergent histologies. So I think this is really important data as we look at that overall. So overall, in the first reported data for CDK4/6 inhibitors in RCC, single agent active abemaciclib had no clinically meaningful activity in heavily pretreated disease. No new toxicity signals, although I would argue it was patients didn't enjoy it. I'm sure if we did a PRO, it would not have been the greatest results, but maybe partly because of the disease progression. This data may inform interpretation of ongoing trials exploring novel combinations, including CDK4/6 inhibitors. And I want to thank my co-investigators and the patients and their families for enrolling in this trial.
All right. Well, so exciting to see all this fresh new data get presented. So we're going to open it up for questions. We've got 15 minutes for questions for our 3 speakers, and then we'll transition to the next 3 speakers. So open it up to the room. Lisa.
Thanks, Darren Feldman from Memorial Sloan Kettering. My question's for Toni in your pooled analysis. Did you notice any increase in mortality amongst the patients receiving ESAs, as that's been reported before, or any effect on outcome?
Yeah, no, this is a great question. I have to say, I do not recall. We might have done that, but I do not recall it off my head. It's a good thing. I mean, none of the patient I recall that had it, because they overshot their hemoglobin. The data, for increased mortality comes in solid tumor that were supposedly could be cured with localized therapy. That's all the data, around ESA. And that's a problem we want to encourage because a lot of physicians don't want to use them. What I do in general, I get an iron panel, I get an EPO level. I make sure, the patient is not iron deficient first. Then I use ESA ahead of blood transfusion, at least in my practice. We could look at this data in other countries. At least the rest of the US, we've seen a lot of use of blood transfusion simply because not just the ESA fear, the ease to get a blood transfusion in the US, which is not the same at other places. We should be looking at this analysis.
And you didn't look at response in this. This is just a safety analysis.
No patient that developed anemia or their anemia corrected or ESA did not have better outcomes in a waiver, but specific ESA and mortality we haven't. Good question.
To piggyback on Darren's question, anything with the VTEs that would be interesting to look at as well if you're going to look at OS with the ESA treated patients. Other, Lisa? Oh, Mike?
Yeah, I have a question. So for all of you Belzutifan experts, if you have a patient who's progressing on a TKI, do you just stop the TKI and start Belzutifan? Or do you add Belzutifan and taper the TKI? Or do you do something else?
With regard to the part of the clinical trial and maybe because you have access now in the US, you can take to routine clinic. So within the trial, of course, we had to stop before the TKI with a short washout according to the different trials. So the drug was stopped, and then we had Belzutifan single agent. But we also know now, we discussed that earlier today, that we're eagerly waiting the combination trials data as well. Do you want to comment on?
And I just want to ask a question about the trial then. So how many patients stopped TKI and then didn't to go on the trial and then didn't get on the trial because their disease progressed?
Thank you. It's a good question. We've learned over the past decade that we may have some rapidly progressive disease because of the stop of the TKI, especially for those patients that were treated in third, fourth line. That's something we know, especially when you stop a potent VEGF TKI such as cabozantinib. And in this case, we see patients that unfortunately have rapid disease progression. In the trial, the washout was only 2 weeks, Mike. So we didn't have as much as we would have had for a washout of 4 weeks. So that was the chance with this trial.
But how many people were screened and didn't get on, were screen failures?
I don't have it on top of my head, but I'm very worried about the thinking, Mike. I don't think it's wise. And the reason is we thought the same about immune checkpoint inhibitor and CONTACT-3 and soon TiNivo-2. At least CONTACT-3 for now. TiNivo-2 will know this year. CONTACT-3 showed the opposite. So I would imagine continuing immune checkpoint inhibitor, which make probably more sense. That's something with a short half-life that causing so much side effects. We all thought that CONTACT-3 would show something. Not only it was negative, imagine all those infusion the patient came in. Imagine the side effects that are statistically significantly higher. And imagine the taxpayers like you and me paid for so much money. So I have a problem with this strategy. Perhaps in mice, maybe, continuing, but I think we should not keep adding on and piling on. So far, CONTACT-3 didn't prove that's the way to go. You want to do combination? I think we should start just combination like LightSpark 011. It's at the core of my belief. Yes.
Yeah, I would not equate CONTACT-3 to this situation though. But how long what's your washout?
Depending on the TKI half-life, but I don't wait for 4 or 5 half-life. I'm very happy after 1 half-life. It also depends on the insurance washout, right? This is not, you can't go to Walmart and get it 24/7. So usually I have no problem. Axitinib short half-life, even cabozantinib, this 4 plus 4.5 half-life is a fallacy because that's if you think any drug dosage for anything half-life is very short. Here I don't mind within few days, even to start something.
And Brad, you were going to say something?
Yeah, I agree. I think we know that it's safe to give Belzutifan with a TKI. So I'm very quick. Like when patients progressing outside of a clinical trial will stop the TKI. And usually whenever they get the Belzutifan within a couple of days, I'm happy with them starting it at that point in time.
We're going to see LightSpark 11. It's a very, very important study. We're looking at it. We're going to look at it under the microscope, really electronic microscope, to look at safety, tolerability, to look at signs of efficacy, of enhanced responses. Obviously, the data with Cabo and Belzutifan, now I have to say, in untreated patient is almost too good to be true. It's great. We led the study, but 75% response, durable in our hand. There could be something there. That's why we're going to dissect LightSpark 011. I think it's one of the most important studies we're looking forward to. Yeah. Anemic patients are not hypoxic, so totally different. But physiology. But I mean, there are multiple mechanisms, and one of the 3 Nobel Prize winners did a lot of work on this, not Bill. So there are 2 theories. The early theories was the carotid body, response here that could be dependent on HIF2, that could be altered with HIF2 inhibitor. But the one that is more plausible is the VQ mismatch in the lung. So HIF2 has physiologic role in the lung in adjusting to this mismatch that happened in several areas of the lung. We think the lung, it's all one balloon open and life is good. No. It's very patchy in terms where areas where air goes, and HIF2 inhibitor accentuate that. There's also the problem with altitude and etc.
Is there any difference between tolerance of the patient? For example, patient with COPD more sensitive to hypoxia, but we see some patient come to the clinic that say with 75 but asymptomatic.
So the answer is, I don't want to be the guy that only did Belzutifan. So Brad has been very much involved. Renal, Laurence, you want to take it?
Yeah, I often find patients may not be symptomatic from hypoxia. So I think it's important to tell patients to check their pulse ox on a regular basis, because I've had patients come in feeling fine, maybe a little headache, and the pulse ox is in like 80. So I tell patients always to be checking their pulse ox at home on a regular basis and let me know if it's dropping, because they often may not feel short of breath.
I think poor lung function, etc. it's, we've seen more in terms of percentage of hypoxia, etc. But we've also seen patients completely healthy, 100% room air, developing also hypoxia. So it's not, 0 and 1. This is not bimodal. But I think with more poor, function, lung function, we've seen cases during the pandemic of folks getting COVID, and I would not expect them to be much hypoxic, but they were on HIF2 inhibitor. They were on Belzutifan, became more than what you expect. However, I would say the drug half-life is short. So that's an advantage here.
Yeah, I think it speaks to the fact that we need to generate real world data now that we're getting into a patient population that is broader than the one we had in the trials, so that we can answer those different questions.
I think speaking to the hypoxia, I think people that have high burden of lung disease or have concern for lymphangitic spread, those are the people that I think have made me a little bit worried around the hypoxia. It'd be interesting to see if target lesions in the lung or anything like that could correlate with hypoxia developing.
So Brad, a quick comment and then maybe an idea coming out of that. So the original evidence preclinically is that CDK4/6 loss was synthetic lethal with VHL loss, right? So you would imagine based on that CDK4/6 alone, inhibition of CDK4/6 alone would be sufficient to kill a VHL deficient cell. There was additive effects with the HIF2 inhibitor and CDK4/6 inhibition, even in cell lines that were otherwise not alone responding to HIF2 inhibition. So in my mind, I don't know if Bill has seen this data, but I think in my mind, as soon as he sees this data, given that there are already 8 or 9 prior lines, there is a very strong chance that the cells have already selected for either mutated RB or have selected for pathways that are no longer RB dependent, right? So I think a very simple analysis would be to look for RB phosphorylation, mutation status, E2F activity, cyclin D1 actually, which I think is a biomarker now for even Belzutifan response, would be really relevant if you're going to combine it even in the other trial. So I would be thinking along those lines. That it's flat, a disappointing result. There's no way of explaining it
I
away.
agree. So, Bill has seen the data and we were all equally disappointed. I think to that point, we don't have like fresh tissue biopsies or anything like this. So I don't think we'll be able to do that. We have like tissue, archival tissue. So we're going to run like an Onca panel and look for any of those things. But I think to your point, it's not real time. And so I think the number of prior therapies is certainly played a role in our results.
Yeah, but I strongly believe in single agent activity. There are a lot of examples in oncology of, more synergy, drug by single agent, doesn't work. In combination, it works. There's still, despite the example we can give, like trastuzumab single agent metastatic versus plus chemo, but these are probably less than 5% of all successes.
Okay.
So, and there was nothing in the literature. Surprisingly, with all the phase 1 of multiple CDK4/6 inhibitors, there was not a single patient we found, or two, one treated with RC as first line, and that's where we didn't have PD-1 inhibitors. So we had to do the study.
I think the rationale, all I'm saying is the rationale originally was the VHL deficient cell lines are going to specifically be impacted, not the VHL proficient surrounding tissue, right? The synthetic lethality was VHL loss.
Right. This is clear cells, so you expect. Hopefully we're able to publish it. I'm going to ask Dr. Powles if he will accept the rapid publication in Annals of Oncology. No? Okay.
Yes, Tom?
Is our research boundary better placed outside of
So no, I think we show that like.
It's very true. Because if you showed this to a patient, you showed your gravity findings, you will what's going on. They'd say, look,
well, let's do something different. This isn't going to change everything. It's not going to cure kidney cancer. Those drugs, it's not going to cure kidney cancer. I don't think anyone thinks it's going to cure kidney cancer. And that's what we're trying to do. And if that's the case, why don't we do something else? Because we can't do everything.
I don't think you can exclude synergy at all. So I think still there is enough preclinical data to do a HIF2 plus minus, maybe not 1,000 patient study, but a HIF2 plus minus CDK4/6 inhibitor.
I would probably not do that.
Well, we're not going to.
So I've done enough negative trials in my career to know that this program is not going to end up changing the way we treat kidney cancer. And I think we should look at new areas.
I'm going to report you to Bill Kaelin.
Okay, this will be our last comment/question. Yep, go ahead.
I have to agree with Tom. There is actually another preclinical data set from Novartis with HIF2 alpha and CDK4/6, which was negative preclinically. So for the single agent CD4/6 inhibitor in RCC and in combination. So I really tend to agree with Tom that I think, unfortunately, for the program, I wouldn't pursue this.
Yes, thank you. Thank you for the question. Now we have to move the next three. And the first is Eddy Saad from Dana-Farber Cancer Institute.
Thank you for the opportunity to present. So, as you all know, the use of immune checkpoint inhibitors is associated with a new set of toxicities known as immune-related adverse events, or irAEs for short. These adverse events can be severe, they can lead to hospitalization, to death, and overall limit the effectiveness of our treatments. This is why there's an urgent need to develop biomarkers that can be used in the clinic in order to stratify the risk for each patient and therefore tailor our therapeutic strategies. However, this task is not easy, and the reason for that is that the mechanisms underlying the development of irAEs can be complex, and they depend on a series of both extrinsic and intrinsic factors, as you can see here on the slide. In our previous work, we identified inherited germline biomarkers that can serve as reliable biomarkers for immune-related adverse events because of the fact that they are stable in each patient and they are easily accessible. And this is the figure from this paper led by Dr. Gustaf's lab. A genome-wide association study, or GWAS, was conducted on 1,700 patients. This is a retrospective cohort of patients from Dana-Farber, and they identified a SNP in the intronic region of IL-7 that was significantly associated with a higher risk of immune-related adverse events. The aim of this study was to characterize and validate the association between the IL-7 SNP and adverse events in two prospective randomized phase 3 clinical trials of patients with cancer treated with ICI regimens. And these are the two trials that were used in this study. The first one is Checkmate 025, which I'm sure you're all familiar with. This is a trial of 821 patients with advanced RCC that were randomized to receive either nivolumab or everolimus. Whole exome sequencing data were available from tumor and blood samples, and we were able to successfully infer the SNP using the STITCH pipeline. And this is the second trial, the Intrepid Lung or BTA-037 trial. This is a trial in advanced non-small cell lung cancer where patients were randomized to receive either bintrafusp alpha or pembrolizumab. And for the sake of this analysis, we only focus on the pembrolizumab arm. Whole exome sequencing data was available from tumor samples. However, since we were not able to infer the SNP from these data, we used a surrogate SNP with an R-square of 0.66. The association between the SNP and adverse events was tested using a time-to-event analysis using Cox proportionate hazard models. And so our first aim was to investigate whether these SNP carriers exhibited differential or distinct clinical and tumoral features. So starting with baseline clinical characteristics, these were similar between SNP carriers and non-carriers. The only exception was the sex distribution in Checkmate 025. We then used whole exome sequencing data from Checkmate 025, and we investigating the somatic alterations within these tumors. And as you can see here in these two oncoplots, the frequency of the commonly altered genes was similar between carriers and non-carriers. In the BTA-037 trial, we used IF data to look at the immune infiltration within these tumors. And we once again did not detect any difference in terms of immune infiltrates, whether inside the tumor itself or in the tumor microenvironment. And these are the adverse event profiles within each treatment arm. For nivolumab and pembrolizumab, these were consistent with what is normally seen with PD-1 inhibitors, so endocrine, GI, and rash or skin toxicities. And same goes for everolimus. These were also consistent with what is previously known. Now, moving on to the primary objective of our study, meaning the association between the IL-7 SNP itself and adverse events. And you can see here in these Kaplan-Meier curves, in both the nivolumab arm of Checkmate 025 and the pembrolizumab arm of BTA-037, IL-7 SNP carriers that are depicted here in red had a higher risk of immune-related adverse events. This was not the case for the everolimus arm of Checkmate 025. And once again, this is a univariate analysis, and this is why we also conducted a multivariable analysis using a multivariable Cox regression model, accounting for age, sex, purity, race, and ECOG. And once again, you could see that in both the nivolumab and in the pembrolizumab arm, there was a significant association between the IL-7 SNP and immune-related adverse events, with significant hazard ratios of 2.91 and 2.3. Now, in order to formally test for the predictive ability of that SNP, we performed an interaction test between the SNP carrier status and treatment arms. And we found a significant interaction term, meaning that the IL-7 SNP was predictive of adverse events only in the nivolumab arm and not in the everolimus arm of Checkmate 025. Now that we have established that SNP carriers have a higher risk of occurrence of a first adverse event, the remaining question was whether these individuals were also prone to develop multiple or recurrent adverse events. And in order to assess that, we used a Gill-Anderson model that tests for recurrent adverse events. And once again, in the Checkmate 025 trial, we were able to demonstrate that the IL-7 SNP was associated with recurrent adverse events in SNP carriers. And this was only the case in the nivolumab arm and not in the everolimus arm. Our final question was whether the SNP carrier status affected survival outcomes or the efficacy of our treatments. And these are the Kaplan-Meier curves from the nivolumab arm from Checkmate 025 And as you can see, SNP carriers and non-carriers displayed similar progression-free survival and overall survival. And I should also mention that that was also the case in the pembrolizumab and the Everolimus arms. So in conclusion, this previously identified IL-7 SNP is associated with a higher risk of immune-related adverse events. This also includes recurrent events in the same patient in 2 phase 3 trials of patients with metastatic RCC and metastatic non-small cell lung cancer treated with single-agent PD-1 inhibitors. This association is selective to ICI regimens, and furthermore, it does not affect survival or the treatment efficacy. And for all of these reasons, the SNP can be viewed as a predictive biomarker for immune-related adverse event and can be used to guide therapeutic decision. Now, our future directions involve trying to elucidate the mechanisms by which the SNP can cause or is associated with more adverse events, but this is still work in progress. I would like to finally thank everyone who contributed to this work, especially my PIs, Dr. Choueiri and Dr. Gustave, the whole Dana-Farber team, and first and foremost, the patients and their families. Thank you so much.
Thank you, Eddy. The next speaker will be Carcinoma from Dana-Farber Cancer Institute. Please, Carl.
Hey, everybody. I'd like to thank KCRS for the opportunity to present our work. And I'll start with a little bit of background. As some of you may know, sarcomatoid features in RCC are associated with a more aggressive disease. And so patients with sarcomatoid RCC have usually worse prognosis. However, fortunately for the patients, the sarcomatoid RCC tend to respond well enough and do great when they receive immunotherapy regimen. However, there is a challenge here, is that the detection of sarcomatoid features on pathology is challenging. It is affected by spatial heterogeneity and sometimes sampling error. Therefore, arises the important need and unmet clinical need to develop a liquid biopsy tool that can detect more accurately sarcomatoid RCC in patients, overcoming the challenges of spatial heterogeneity and sampling error, and which will finally allow us to administer the right therapy for the patient with RCC. Therefore, the aim of our team here was to try at least to suggest an approach for blood-based detection of sarcomatoid RCC to guide therapy selection in RCC. So we gathered a tissue cohort of 8 sarcomatoid RCC and 8 non-sarcomatoid RCC. We proceeded by profiling the epigenomic library of HCK27 ChIP-seq on these samples, and then we sought to investigate and determine the differentially marked regulatory elements between the two histologies, sarcomatoid RCC and non-sarcomatoid RCC. And then afterward, we proceeded with our plasma assay that was described by our group recently in Nature Medicine paper. The technique is called selfie ChIP-seq, and it allows us to capture histone mark in ctDNA. We focus here on HCK27 acetylation histone mark, and afterward, we calculated a sarcomatoid score for each sample, which was derived by aggregating the HCK27 acetylation signal in ctDNA at the tissue-derived sarcomatoid-specific regulatory elements, while normalizing this signal to the signal that was present at the epithelioid or clear cell-specific regulatory elements. These scores were compared between the two cohorts of plasma sarcomatoid, non-sarcomatoid, and then a classifier was built, and its performance was evaluated using the area under the receiver operating characteristic curve. As for the results, and here I'll be showing first the tissue cohort, we can see that the epigenomic features between sarcomatoid and non-sarcomatoid are widely different, as you can see on this unsupervised hierarchical clustering and PCA. And therefore, this suggests that as one would expect to find thousands, as we can see, thousands and thousands of differentially marked regulatory elements between these two groups. And so, using these differential regulatory elements, and as we described, we derived this sarcomatoid score, and strikingly, as you can see, the plasma samples coming from patients with sarcomatoid RCC had significantly higher sarcomatoid scores compared to the plasma samples coming from patients with epithelioid clear cell non-sarcomatoid RCC, achieving an area under the curve of 0.89. we then thought to incorporate or integrate another feature to our model to maybe enhance its performance. And this rationale arises from a previous also work that we did and published with our team with Talal al-Zarif, where we characterized the epigenomic landscape of sarcomatoid RCC in tissue. And one of our interesting findings was that HIF2 alpha, which is now described as one of the driver of RCC, was downregulated in sarcomatoid. And so since our assay allow us to sort of, to a certain extent, infer the activity of transcription factors in plasma through this self-retrieve technique, we sought to calculate the transcriptional, or at least estimate the transcriptional activity of HIF2 alpha in the plasma samples. And strikingly also, we can see that the sarcomatoid plasma samples had significantly lower transcription activity at the HIF2 alpha binding sites compared to the epithelioid RCC plasma samples. And so integrating these two features now, we're able to enhance our model, and we have now a prediction of 0.92 and distinguishing plasma samples coming from sarcomatoid RCC patients from non-sarcomatoid RCC patients. So in conclusion, we present here the first proof of concept study for the detection of sarcomatoid differentiation in RCC based on tissue-informed assessment of cell-free DNA epigenomic profiling. And this approach, interestingly, requires just 1 milliliter of plasma. This approach could overcome the challenges that we discussed, the spatial heterogeneity, the sampling error that usually make the identification of sarcomatoid RCC difficult. And also another advantage of this assay is that it offers a means to infer the activity of targetable transcription factor in cancer. And of course, our method establishes now a paradigm for identifying histologic subtype of cancer based on their epigenomic signature in cell-free DNA. I'd like to thank the wonderful team behind this work, especially my PIs, Dr. Baka, Dr. Choueiri, and Dr. Friedman. And all my colleagues and friends at the lab. Thank you for your attention.
Thank you, Carl. The last speaker of this session will be Nazlı Dizman from MD Anderson Cancer Center. Please, Nazlı.
Thank you, Dr. And actually, this is the first time my first name is pronounced perfectly well for a long time. Good afternoon, everyone. Very nice seeing you all here. I first wanted to thank the organizing and the scientific committee for allowing us to present our research here on the stage at KCRS today. I'll be talking about the CBM588, which is a live bacterial product that contains Clostridium butyricum, a butyrate-forming anaerobic spore-forming bacterium that has been used in GI conditions in Japan for the last decades. Preclinical studies with CBM588 suggested that this compound protects the intestinal barrier function under the conditions of antibiotic-induced dysbiosis. Our team in the past few years published 2 phase 1 randomized clinical trials examining CBM588 in conjunction with first-line immune checkpoint inhibitor combinations in patients with metastatic RCC. In the first study, we randomized patients into either Nivo-IP or Nivo-IP and CBM588. And in the second study, we randomized patients into either Nivo-Cabo or Nivo-Cabo and CBM588 arms. The last study was published a few weeks ago by our colleague, Dr. Ibrahimi in the Nature Medicine. And for both studies, we collected stool samples at baseline and week 12. And the primary endpoint was a biologic endpoint, the change in the abundances of the Bifidobacterium species, a species known to be beneficial in the setting of immune checkpoint inhibitors. In terms of the primary endpoint in both studies, we did not detect any statistically significant difference in the levels of Bifidobacterium species from baseline to week 12. However, in patients who received CBM588 with nivolumab and ipilimumab and had response to treatment, we've seen an increase in the bifidobacterium species that may be suggesting that a certain proportion of patients may benefit from this compound, have modulation of the gut microbiome, and have response to this treatment. Interestingly, in both studies, we've seen improvements in clinical outcomes in the CBM588 arms. Some of them are included here, but overall the results encouraged us to further examine the impact of CBM588 on gut microbiome now that we have 2 studies. In this project that I'm going to be talking about today, we combined 2 studies and included the patients who received nivo-ipi or nivo-cabo in the standard of care cohort, and patients who received nivo-ipi, CBM588, or nivo-cabo and CBM588 were included in the standard of care and CBM588 cohort. We examined the changes in the abundances of clinically relevant species and phyla. We also focused our attention to the ratio of firmicutes to bacteroidetes, which is a measure of gut dysbiosis commonly used in microbiome research. I'll start with patient characteristics. They seem to be similar across the 2 cohorts owing to the randomized nature of the 2 studies. If I may say, we first looked at alpha and beta diversity and their change from baseline to week 12 in both cohorts. Both for diversity measures and the microbial richness measures, we didn't detect any statistically significant changes over time in both cohorts. At the species level, we first examined bifidobacterium species. As expected, it hasn't changed from baseline to week 12 in both arms. As expected, based on the results of the 2 studies included in this pooled analysis. We also examined several species that have been shown to be associated with clinical outcomes in the setting of immune checkpoint inhibitors in several disease types. And among all, Eubacterium cerium was one that stood out as with the most striking evidence showing a decrease in the standard of care cohort and remaining stable in the standard of care and CBM588 arm. This species is one of the species that has been repeatedly shown to be associated with better response to immune checkpoint inhibitors, mostly in melanoma. We examined determinants of gut dysbiosis at phyla level in this pooled cohort as well. The good proportion of the dysbiosis-eubiosis ratio, bacteroidetes have increased in the CBM cohort, while the bad proportion firmicutes have decreased, and both phyla has remained unchanged in the standard of care cohort. And this was reflected onto the ratio of bacteroidetes and firmicutes. The ratio has increased in the CBM cohort, whereas it was stable in the standard of care cohort when baseline and week 12 samples compared, suggesting a shift towards a more eubiotic microbiome signature with the addition of CBM588 in first-line setting with immune checkpoint blockade. For conclusion, our findings suggest that supplementation with CBM588 leads to a correction of gut dysbiosis and prevents depletion of species associated with immune checkpoint blockade response. We continue our preclinical studies with CBM588, and phase 3 randomized trial is being planned under SWOG to examine the clinical activity of CBM588 in combination with first-line immune checkpoint inhibitor-based combinations in metastatic RCC. I would like to take my last 25 seconds to thank our patients and their families for their volunteering for both studies, and GU Medical Oncology team at City of Hope, especially Dr. Paul, Dr. Hedi Ibrahimi, and our collaborators at TGen, Osal Mirisan, and funding support from Gateway Foundation and Excelexis. And thank you all for your attention.
Thank you to all presenters. We are on time, and now we have 15 minutes for Q&A session. Please.
Great session. First to Eddy, question, and then to Nazli. Eddy, great work. So where do you go with this IL-7? Did you first look at severity of the grade? I mean, you mentioned irAEs, but did you look at IL-7 SNP with grade 3-4 or grade 1-2? That's one. And then we all know that the main immune-mediated effects, the highest would be with nivo-ipi than with anti-PD-1 alone. And that's what we worry about. Are you carrying this now, IL-7, to look at, say, checkmate 214 and see if this IL-7, is also relevant in the nivo-ipi arm? So that's for Nazli. Did you control for diet? We know that, it's not just CBM addition to did you control in both arms, in both studies for diet? Because we know fasting affects the microbiome. Diet, high fiber versus low fiber or normal fiber with that. Did you control for that? Thank you.
This is a great question. As you mentioned that the fiber intake is significantly associated with better response to immune checkpoint blockade and fasting as well. Our studies were planned before the fiber studies came out. We have dietary logs from each patient collected, but unfortunately, we do not know the amount of the food they consumed that day. We just know what they ate. So this is not sufficient data to calculate the daily consumption of fiber or other micronutrients. So we have been challenged with that problem since the beginning of the first study, but we are implementing 24-hour recall questionnaires for the newer studies in the future. So these results do not include any adjustment for dietary consumption. Though I may need to mention that none of the patients received probiotic aside from this study. That means that the control arm in the study were restricted from receiving any type of probiotics, including yogurts, during the duration of the therapy. So there was a minor dietary intervention in that small cohort.
Eddy?
Thank you, Dr. Tanya. So for our analysis, we restricted the analysis to grade 2 or higher adverse events. The issue with grade 1 adverse events is that they aren't very specific. And for grade 3 or higher, we did observe the same trend. However, because we had less events, it was no longer statistically significant. However, in some other replication cohorts, we looked specifically at adverse events requiring steroids or requiring hospitalization, and there was definitely a significant association. And for your second question, so in the Dana-Farber cohort, we looked specifically at a subset of patients having received CTLA-4 inhibitors, either as monotherapy in the context of melanoma or as combination therapy with nivo. And we did observe the same association. We are trying to look at that into the context within the context of a clinical trial such as Checkmate 214.
David?
Just a question about the CBM588. I find the clinical data super interesting, and then the mechanism is more difficult. And I think a lot of the focus has been on sort of correcting gut dysbiosis, but maybe a naive question, but it produces the bacteria produces butyrate directly, and that's known to improve CD8 T cell function. Is there a way to just measure, is there higher butyrate levels in the plasma? Are the CD8 T cells more functional, better cytokine production, just more direct mechanism?
This is an actually excellent question. We got a KCRS24 to look at the short chain fatty acid levels in the blood samples collected in that study. We assume that the higher production of butyrates in the GI lumen would correlate with the circulating levels of short chain fatty acids. In patients who responded to treatment, we do actually have an increase in the butyrate levels in these patients, but the results are we are still doing further analysis in that data set. So I'm not sure how strong it is. This is also from a fact that short chain fatty acid level detection in samples collected a year or two ago is a little bit challenging because usually the samples should be sent to the lab right away for mass spectrometry. And then at the same time, the patient needs to be fasting for better depiction. There are a few studies in the literature that serum short-chain fatty acids are less predictive of a response of immune checkpoint inhibitor than the stool short-chain fatty acid levels, in fact. But that's all another challenge. But in my studies, we'll be able to check both of them in a timely manner, hopefully understand later.
There's a great follow-up to David's question. I was actually going to think about the same idea, but in a different context. The Clostridium is going to be an anaerobic bacteria that's going to probably go and colonize some part of the tumor also possibly. So you might not see a massive change in circulating levels maybe, but you'll probably get a localized, in the kidney TIF, for example, a localized increase in several metabolites, including the short-chain fatty acids, which would impact the epigenome of the RCCs. We are doing these screens right now in vitro with a number of microbial metabolites that we know are impacting directly the biology of the RCC cells and could be therefore impacting how the immune cells are seeing them. Metabolites to think about, although butyrate is one easy low-hanging fruit, but I would not ignore all the other tryptophan / indole, etc., that other model systems are actually scoring as regulators of the immune system to think about. But bottom line being that the bifidobacterium and the firmicute ratio could be a good biomarker, but I don't know if those differences are driving the immunological response. What's probably driving the immunological response is a more direct effect. In the animal studies, especially, I would strongly suggest that you all have a heat-killed bacteria as a control to demonstrate whether or not there is a direct activity of the metabolite products of the bacteria.
Awesome. Thank you so much. Yeah, totally agree. And I'll add your last suggestions into our new proposal as well.
Lisa?
I have a question for Eddy. So I think I missed whether this is a coding or a non-coding SNP. And if it's coding, have you done any structural modeling to try to understand how it might be impacting IL-7 function?
Thank you, Dr. Henske. So I did not have the time to go in depth into that, but we do have evidence to suggest that this SNP, which is located in an intronic region of IL-7, actually causes the expression of a novel cryptic exon. Which translates into a novel mRNA isoform, but we have reason to suggest that it might also translate into a novel protein isoform. This is currently an area that we're trying to explore in the lab. It has been a bit difficult to test, and there has been some issues with the structures of the final IL-7 because the way that this cryptic exon works is that it might start by and this novel cryptic exon could be the start of the novel protein, which would result in the loss of the first two exons. However, these first two exons are necessary for the interaction between the IL-7 and its receptor. This is why we are also trying to see what potential effect could that be in terms of regulating either T cell functions or even B cell function.
This is also for Dr. Saad. I'm over here. Did you look at any measures of response? Because we know that people who have, worse irAEs are more likely to have better response.
We did not see an effect in terms of objective response. However, in one of these other cohorts, we validated the clinical opinion saying that people having low-grade adverse events tend to have better survival. At least because when people also have higher grade adverse events, there's also the confounding factor of that. However, for the SNPs effect in particular, there is no effect in all of the cohorts that we tested on either survival outcomes or response.
Okay. And a quick follow-up. There were also two other SNPs that looked like they were, are you looking at those also?
I'm sorry.
I thought there were two other SNPs that we saw at the beginning that were you looking at those also?
Oh, for the other two SNPs, they did not replicate in the other validation cohorts.
Question for the circulating chromatin. To me, that's one of the most exciting assays that's out there because it seems to be very sensitive. You said you need just 1 cc, etc. Do you think there would be a possibility to detect residual chromatin or shedding in the post-nephrectomy space, adjuvant space? Number one, and then for Nazli, for your dysbiotic, protection, so to say, do you see any effect on potential colitis, frequency, etc.?
Thank you for the question. Thank you for your question. So yeah, this is a great question. And I'd like to mention first that the cohort we presented here were all metastatic RCC disease. I think we still need to do some decent work in order to allow this assay to be sensitive to minimally residual disease. However, I think in sarcomatoid, in the field of sarcomatoid RCC, most of the patient or a good portion of patient present with already metastatic disease. This is why I think this, even though it might not for now detect minimal residual disease, it has still great clinical implication now. And we are working currently to optimize the sensitivity of this assay. And of course, optimally, in the future, we would like to be able to monitor patients from nephrectomy and try to predict if they will be cured or not.
For my question, I think we have looked at gut microbiome signatures of patients with immune-related adverse events and not, but we have not looked at gut dysbiosis and its association with the immune-related adverse events in this combined data set. In terms of colitis, luckily, in the entire data set, we only had a handful of patients who had each adverse event that we know. So none of them stood out as so significant, and it would be challenging to do analysis with that small number of patients. But I agree that we could actually look at the dysbiosis in patients with grade 3 adverse events versus not.
And then one follow-up for the SWOG trial that you teased us with. Is there going to be a dual immune checkpoints or carbonivo? What's your preference?
I think discussions are still ongoing. One option is Nivo-IP, another option is Nivo-Cabo. I feel like I don't have any preference.
It's Nivo-Cabo. Is there any other question from floor? If there is no question, I will have a question for Toni. What is your expectation for the Euro Cup match between England and Spain?
Yeah, no, I mean, we know that the UK team here chokes every time. They do choke. I remember the last time was 1966. Tom, we're talking to you. Yeah, no. Yüksel asked about the prediction for Euro. England, that's true. England.
After my prediction around PARP inhibition, I don't think I should comment.
Oh, yeah. No, but I think
wrong about that as well.
It will be 4-0 Spain. You know that.
I'm not worried about that. I'm excited by the journey. It's not about.
Oh, boy. Remember last time, 1966. We weren't both born. Okay, great.
Okay, I think there is no more question, and now we have a break. Thank you for all.